Good morning, everyone, or good evening, depending on where you are, and welcome in 2022 Summer Academy for Pluralism Economics. We're glad to have you here, and first, let's start by presenting our event by a quick teaser. Wonderful. So before we get started, I'd like to go over a few items so you know how to participate in today's event. So you will have the opportunity to submit your message in the message bar below your screen in the control panel. So you have two options. Either you could type in your message anonymously. So in that case, I'm gonna just read your message to our lecturer to have your questions answered. Or you have another option to type your message showing your names. In that case, you will have the chance to ask your question directly. And I would love to emphasize that our event is recorded. So if you think that if you want to ask your question directly, put in your mind that your voice will be recorded. So today's event is all about uncovering insights on the long-running debate on public or private provision of essential public goods, such as healthcare, and focus essentially on lessons from the current disruption caused by COVID-19, global conflict, and ecological crisis. So now let's introduce our speaker. So today's lecture will be held by Dr. Martin Hensher. So Martin is the Henry Baldwin Professional Research Fellow in Health System Sustainability at the Menzies Institute for Medical Research of the University of Tasmania. His research focused on integrating the economic, environmental, and social dimensions of improving the sustainability of healthcare systems. During the COVID-19 pandemic, he has led the work on estimating the likely impact of COVID in Australia, the application of digital technologies, and the problem of privatization knowledge in the pandemic. Professor Hensher has over 30 years of experience in health economics, planning, and financing, gained in UK, Australia, Africa, Europe, and Central Asia. He was the senior economic advisor in the South African National Department of Health and the Department of Health in England, before moving to Australia, where he spent 7 years as a director to the Tasmania Department of Health. Welcome, Dr. Martin, and we are so glad you could be here today to share your insights on the revising the role of public and private institutions debate of the backdrop of the global health crisis.
Thank you, Rita, and thank you to the organizing committee and everybody here. So good morning to you. It's evening here. So the other thing I have to say thank you for is letting me do this evening lecture in the morning. That's helped me with the time difference. So thank you very much. Right, I will share my slides and then let us go. So how is that? Does that look okay?
Perfect. Yeah.
Fantastic. Okay, very good. So before I begin my presentation, I'd just like to acknowledge the Palawa people of the Lutruwita nations, who are the traditional owners of the lands where I am today and where I'm speaking from. And I pay my respects to their elders, past, present, and future. And I recognize that sovereignty was never ceded by them. So Rita said a little bit about me. I have had a very interesting but diverse career, really, but mainly around health and healthcare in different countries, usually, but not exclusively, with an economics focus. So, but that's health economics is kind of the angle I come from. But just in more recent years, in the last few years, I became very interested in heterodox economics and ecological economics specifically, and very late in life. I've finished my PhD this year, which was about applying ecological economics to healthcare sustainability issues. So if any of you out there are wondering whether you should do a PhD now or not, I'm proof that you can still do it at the other end of your career, but it might be easier to do it when you're younger, is all I would say. But that's how I've come to be interested in this work. And really my day job at the University of Tasmania at the moment is to develop a program of work bringing ecological economics principles to bear to look at how can we make our healthcare system more sustainable for the future. And so I'm interested in lots of things, the more technical end of how we might incorporate ecological impacts into our economic evaluations of healthcare, but also very much at the macroeconomic end of what might it look like to run a healthcare system in a post-growth environment, whether that's degrowth or steady state or whatever. We can all maybe talk about that in the discussion, but what does that look like? So my focus today, though, is perhaps more organizational than pure economics, if you like, really talking about this long-term debate about public versus private in healthcare. And I'm going to walk you through a few things, but I want to start though by just talking about growth, economic growth, health, and healthcare. So many of you will have seen this graph or a graph like it, which really shows us that economic growth in the way we understand it today is really new. Until about 300 years ago or so, there just wasn't really much GDP growth. The economy didn't really grow very much. It just chugged along. And then suddenly we had this incredible explosion of economic growth around the Industrial Revolution. And with it, almost precisely at the same time, came an extraordinary improvement in human health. So this just graph shows you life expectancy. The one to look at really there is the pink line, which is data from the United Kingdom, where we have pretty good data going back 600 years really now to tell us about life expectancy in England, and very much on cue, not too long after the Industrial Revolution, life expectancy in the UK started going up. Interestingly, straight after the Industrial Revolution, actually life expectancy reduced a little bit because conditions were so terrible in the kind of the new industrial cities, but quite quickly there's this path of increased life expectancy, which then we see being repeated around the world, even in lower income countries. So growth and health in the modern world are very closely linked. And when we end up talking about what's a post-growth future for health and healthcare, we need to remember that actually these two things have been very closely related so far. And health care is also very closely related to economic growth. So health, just for the state of for our definitions, if you like, health is the state of well-being, sometimes absence of disease or general well-being related to your physical and mental health. So health is a state. You or me, we are healthy or sick, but it's a state of being. Health care is the services, the industry, the things we do if we are sick to make us better. So it's really important to just understand these are two slightly different concepts. Clearly, healthcare and health are closely related, and the aim of healthcare, it doesn't always achieve it, but the objective of healthcare is clearly to improve your health, and hopefully it does. But many other things impact health as well, many of them actually more than healthcare. So, you know, economic well-being, access to safe water, access to decent food, housing, etc. Those are the critical drivers actually of basic health. But then healthcare is an important thing, particularly in the more recent past, which has helped to continue our improvements in health. And this graph just shows you for 3 high-income countries, that over the last 50 years, healthcare has grown massively, and it's also grown as a share of the economy. So in 1970, in the United States, the healthcare sector, so spending on healthcare, total spending on healthcare in the United States was about 6% of US GDP. Today, it's over 18%. So 18% of the whole US economy is healthcare today. In Japan and the United Kingdom, a bit less extreme than the US, but actually still very much the same trend. So 50 years ago, about 4% of GDP in those two countries was consumed in healthcare. Now, both, well, the UK about 10%, Japan more like 11% now. So the share of healthcare in the economy has grown steadily for a number of reasons, a bit to do with aging, but actually much more to do with the technologies that are available to us and the fact that we just keep on inventing new drugs and procedures and things that we can do to people. So we're actually providing much more healthcare to more people. And what is though striking is that this is for a shorter period. This shows you low-income countries, middle-income and high-income countries. We only have this data for a much shorter time series from World Bank data, so only from 2000. But what you can see there, which is a bit more alarming, is that you can still see the share of GDP of healthcare growing in the high-income countries, but it's much less clear that it's growing so fast in lower-income countries. So in middle-income countries, you're just about slowly growing share, but in low-income countries, it actually looks like the share of healthcare spending peaked at the time of the global financial crisis and has actually come down a bit since then. So interesting trends and differences between the high-income world and the global south, and as in so many things. The other thing to say about health, so if healthcare is like 10% of GDP in many high-income countries, that means it's a very big sector, depending on how you measure it. In many countries, it might be the biggest single sector of the economy. And certainly, it's very big in terms of how many people it employs. So this graph just shows you health and social care. So social care is maybe things like old age homes, nursing homes. So it's a little bit more than just the healthcare sector. But it shows you that in really more than half of these OECD countries, more than 10% of the workforce, sometimes a lot more than 10% of the whole national workforce, is actually employed in healthcare and social care. So it's a big, big employer. So it's inherently very important then to society and the economy, even just as a source of employment and income for people. But of course, all this is actually happening. All that growing share of GDP is, of course, happening in a period over the last 50, 60 years, where actually the rate of economic growth has been steadily slowing. So we are not yet actually in a post-growth world, but we're in a lot of a lower growth world than we were when I was born, for example. And even in the world as a whole, even with all the growth, particularly in China that we've seen, still the global growth trend is really downwards overall. So I just want you to keep that in the back of your minds, that if healthcare is very closely related to growth, and actually growth is slowing and slowing, where does that go? Where do those curves meet? What happens in those circumstances? I don't have the answer for you, but that's a critical question that underpins a lot of what we're going to talk about. And of course, now we find ourselves in this time of extraordinary disruption, of war, of climate breakdown already visible. So those two pictures there are from Australia. We have direct experience here, but we are now clear that even though we've always had bushfires and floods in this country, there's no question now that they're getting worse, they're getting more frequent, they're getting bigger, the damage from them is getting bigger. Nobody's arguing about that anymore. And then, of course, 2.5 years ago, COVID pops up, this extraordinary pandemic, which has, had such an impact. You may or may not feel it's dominated our lives in quite the same way this year, but the impacts are still massive. So we're in an incredible time of disruption, which is particularly for the healthcare systems and the way what they've had to deal with COVID-19 is unlike anything we've ever seen before. And certainly, I talk to friends and colleagues who are in the healthcare system here and around the world, and this is people of my sort of age, this is like nothing they've ever experienced before in their lives. So there's real questions about the resilience of our systems and where this is taking us. Excuse me. So how I'm going to do this talk and what I'm going to run you through is just really talk about what does it mean, this era of disruption that we've now entered. What does this mean for how we organize healthcare for the future? I'm going to talk a little bit about history, because we can't ever think about the future without understanding where we have come from. I'm going to talk about public and private sort of aspects and debates in healthcare, kind of as it currently is, the current status in some different countries. Talk about some of the key debates in this space. Some of them are old, some of them are newer, and talk about that. And then really focus on what are our challenges? What are the challenges both that come out of COVID and this period of disruption, but also look, there were plenty of challenges even before we ended up in these current crises. So and those challenges haven't gone away. What are they? How do we deal with them? And then finish off by thinking a little about what does this mean? How do we organize healthcare in a post-growth, probably deglobalizing world? What does that mean? Put up some ideas, and then hopefully we can have a good discussion after that. If anybody was hoping that I'm going to give you the answer, you'll probably be disappointed, so you can stop watching now, but hopefully I will give you some good questions and issues, challenges that we can all think about and talk about. So we've had healthcare for, depending how you measure it, a few thousand years. I think you could say we had healthcare with the ancient Greeks, and it's been around since then. So this is a picture of what we'd now call an independent private practitioner from the 17th century. A fantastic, fantastic picture. I hope when you go to your doctor, I hope his surgery doesn't quite look like this, but I do like the cat sitting by the table and the neighbor coming in to watch whatever he's doing to this poor guy's leg. The origin of medicine and surgery lies in people like this. So this gentleman, the surgeon here, he was probably the barber in this village. So you went to him if you needed a haircut or if you needed surgery. So the barbers would pull out teeth, they would treat your wounds. He would probably have somewhere here a bone saw. So if you were really bad and they had to amputate a limb, he would be the guy doing it, with the neighbor holding you down while he sawed off your arm or whatever was necessary. That's where it came from. And he learned his trade as an apprentice. So probably as a young boy, he would be an apprentice to another barber surgeon who he would work with for many years, until as an adult, he was able to set up his own shop. Here's what we'd now describe as a not-for-profit hospital from 16th century Italy. What I love about this picture is that, in fact, this is recognizable as a hospital instantly. Even though what they're doing is completely different, you can tell that's a hospital. So it's amazing that this institution really is still quite similar. In fact, the basis, you walk into an inpatient ward in most hospitals in the world, and it will look a little bit like that, hopefully a lot cleaner. but it will look quite a lot like that. Whereas here are the descendants of those, the barber surgeon and those doctors in that Florentine hospital. These are surgeons in Edinburgh a couple of years ago performing surgery using a surgical robot. So we've come right to the very different end of technology. So there's a couple of things that are very different in this picture. Firstly, of course, is that robot. That's something really very new, but that is gaining a lot of traction. The second thing is very different is that at least one, it's difficult to tell, but probably both of the surgeons in that picture are women, which a few hundred years ago would have been inconceivable. So that's also a big change. And of course, they're in a totally different environment in that they're all dressed in surgical scrubs, they're masked, they're gloved. We're very concerned about infection control. We understand all of that in a way that those people in that old hospital in Florence probably didn't understand what was going on there. So, but these ladies, these surgeons, are still very much the intellectual and professional descendants of this system that has evolved. Here's the first ambulance service that was set up in Australia, which is a fantastic horse-drawn ambulance, 1895. So this was set up actually as a public service by the New South Wales government in 1895. But you can be sure that the back of that ambulance didn't look like this. So today's ambulance is crammed full of equipment, lots of digital monitors, all kinds of stuff in there. There are things in the back of an ambulance today that you would have only found in a hospital intensive care unit 20 years ago, let alone 50 years ago. So a paramedic today can probably do more for you than an emergency medicine specialist could have done in a hospital 40 or 50 years ago. So incredible change. And I think it's important to think about what is it that's changed here. Obviously, the technologies have changed in a way that's the least interesting thing in some of these discussions. Of course, the technologies have changed beyond recognition. But I'd pick out a couple of, or three other big trends which have actually driven a lot of change in healthcare. And the first is professionalization. So that barber surgeon I talked about, as I said, he would have learned his trade as an apprentice, as a little boy, as an apprentice to another surgeon. Those ladies doing the surgery in Edinburgh, they have trained at undergraduate level for 5 years and then done probably about 7 to 8 years of postgraduate training, as well as years of work experience. So they are incredibly highly trained and educated and incredibly professionalized. There are now, in the US, there are 120 different specialties in medicine, and most doctors are only qualified to be one specialty. There are some people manage two, but most people finish their training in one of those 120 specialties, having spent many, many years training, only fully qualifying as a specialist. If you went to medical school straight after high school, you're still not going to be a specialist before you're in your early 30s. So there's incredible professional training. The guy who drove, the guy with the horse, his job was to drive the horse. The paramedics who drive this ambulance have got an undergraduate degree, and most of them will almost certainly have a master's level now in intensive paramedicine. So they've trained for many years. They're very good drivers. If any of you ever get a chance to ride in an ambulance, not as a patient, but in the front with the blue lights on, it's very exciting, and they're very, very good drivers. But there are a lot more than the guy driving that van. They are very highly skilled, highly professional individuals now. Nurses, again, nursing was a thing originally that basically nuns did with no real training. Now nurses everywhere have at least undergraduate degrees, and you will not progress in your nursing career if you don't have at least master's level qualifications. So professionalization is a massive part of what has happened in healthcare. Complexity is linked then to that professionalization and that technology. We have incredibly increased capabilities of what we can do, and that has made the whole system vastly more complex, with lots more different specialist skills, different kinds of professionals, different kinds of equipment, different kinds of drugs that we can now use. Healthcare gets more and more and more complex every few years. The level of complexity is now pretty mind-bending. And as I showed you with those graphs of the share of healthcare in GDP, the sheer scale of healthcare just has got bigger and bigger and bigger. It's been the reliable growth sector of the economy. In fact, that's why, as we'll talk about in a minute, many investors, in particularly the US, are very excited about healthcare because they see it as continuing to be a growth sector, even if other things are not doing very well. So we've got technology, professionalization, complexity, and scale have all, for a good 100 years at least, have all been pushing in the same direction. And one of the questions that we need to think about in a period of such disruption is what happens, and in particular, what happens to complexity. Those of you who are kind of aware of debates about degrowth and, you know, collapse and all of those, the bad things that we're trying to avoid, know that loss of complexity is one of the critical features of collapsing systems. And a loss of complexity in our healthcare system could be very disastrous. On the other hand, it could possibly bring some benefits, and we'll talk a bit more about some of those trade-offs as we go through. Now, I'm going to talk a lot about healthcare systems, and look, honestly, I could give you a whole lecture series on, you know, what's in the healthcare system. We don't need to go there today, but the healthcare system clearly covers everything from what we call primary care, the first people you might see if you went to your general practitioner, or a local clinic if you had a minor illness. It includes the pharmacy you might go to just to buy over-the-counter drugs, all the way up through all different kinds of levels of hospital care, specialist clinical systems, up to very complex, super specialized services that in a country maybe the size even of the UK, you might only have one center in the whole country that provides some highly specialized services. And it also is not just the front end, of course, of the people you see, the healthcare professionals who treat you. It's got a massive supply chain sitting behind it of infrastructure, supplies, the pharmaceutical manufacturing, medical devices manufacturing, you name it. There's a huge supply chain that obviously without which modern healthcare couldn't operate. So the healthcare system covers all of this stuff. And the World Health Organization, quite a long time ago now, has come up with a really good concept, which they still use, which they say there are 6 building blocks for an effective healthcare system. The first is that you need leadership and governance. The second is service delivery. That's the business end. Most of the healthcare system is service delivery. That's the actual delivery of care to people. You need an effective financing system. Your health system financing must work properly. Obviously, you need a health workforce, and you need to be working on making sure that that health workforce is effective and high quality. As I said, you need this whole supply chain of medical products, drugs, vaccines, technologies, increasingly digital technologies in that supply chain. And finally, you need health information systems so that you can make sense, process the data, understand what is happening in your healthcare system. So when I talk about healthcare systems, generally, I'm really talking about this whole thing, all of those 6 building blocks. But you'll forgive me, I will sometimes be talking about service delivery because that's the biggest part of it, obviously. But just think about that's the whole healthcare system. And I'm going to talk about a few kind of in different ways, a few different angles of talking about this, about the organizational aspects or the organizational and economic aspects of healthcare systems. So one angle that we'll talk about is ownership. Who owns different components of the healthcare system, particularly are they privately owned or publicly owned? A fantastic new concept by a researcher called Jennifer Hinton, who has been working on this for a few years, but this is a really important concept that I'd commend. There's some readings at the end of this. And if you don't read any of my stuff, I'd strongly recommend you read her her PhD thesis, actually, which is publicly available, which is about this concept called relationship to profit. Like, what is the relationship between an organization and its mission and profit? We'll talk a bit about that. Financing, I mean, yeah, look, that is a building block of the health system, but it's also actually it's a whole discipline within health economics. So we'll talk a little bit about that. And then a final concept of corporatization or bureaucratization. So like how organizations over time have actually become more corporate, more bureaucratic. And we'll talk a little bit about that and apply those lenses to several of these concepts. So when we break this down and we think about particularly what's in the healthcare system and perhaps the most important kind of organizations and people in the healthcare system, again, we can cut things several ways. So you'll already be seeing the problem with health systems is we're always talking about very complex matrices and intersecting concepts. So I'll try to keep this reasonably simple. But we talk about service delivery organizations. So very simply, a hospital, a group of doctors who work together in a practice, for example, or maybe a pharmaceutical company. There's fairly straightforwardly 3 main forms that they could take in terms of private or public. So we could have a private for-profit organization. So an organization which is just simply a private company that is aiming to make profit, but that is providing healthcare or healthcare supplies and services in some way. We could have private, not-for-profit organizations. Okay, so organizations, they're private, they do not belong to the state or the public domain. So they're private, but they are not for profit. They have a charitable, non-profit mission. And historically, private not-for-profit was incredibly important. So originally, all the early hospitals, certainly in Europe, without exception, were run by religious institutions and thus were what we would now describe as private not-for-profit. And you didn't, in fact, see either for-profit or, more importantly, public hospitals until well into the 19th century. So pretty much everything in healthcare or every hospital was a charitable, not-for-profit organization until less than 200 years ago. And only more recently do you find public hospitals, and you don't really find for-profit hospitals until a lot later, even into the 20th century. And we'll talk a bit more about how that looks today. But so those are 3 key categories: private for-profit, private not-for-profit, and public. Public, look, it can be different in different countries, but it's fairly obvious it is owned by the state or some public authority on behalf of the people. In the health workforce, healthcare professionals might actually operate in different ways. So in many organizations, very straightforwardly, health professionals are just an employee, they're a salaried employee, they're paid by the hospital or the clinic or wherever it is they work for. That's easy. They're employees like lots of other people in the economy. That's easy. Many professionals, particularly doctors in many countries, though, are not actually employees of hospitals or healthcare organizations. They're often the way you would really think about them is they're self-employed. They're independent, self-employed individuals, or maybe they are partners in a medical partnership. And that's, in a way, that's a more traditional form of kind of ownership that has survived in quite a lot of countries into modern times. Then on the financing side, and again, in my last job, I used to teach a whole semester course about health financing. So we're going to cover it in 30 seconds here. So my apologies for brevity. But financing, there's really 4 key types of financing that you need to understand, or you need to be aware of. So the first is what we call private out-of-pocket expenditure. So that is literally, I go to the doctor and I pay the doctor $50 for the consultation out of my pocket, no insurance, no government subsidy, no nothing. I'm paying them the money directly. Private out of pocket. In many systems, there is also private health insurance. So health is a risk, or illness, I should say, is a risk. So over time, people started to try and insure against unpredictable health risks. So one way of doing that is through private for-profit health insurance. So I pay a premium to my health insurance company in the same way that I pay a premium to my car insurance company in case I have a crash. I pay a premium to my health insurer in case I need healthcare. And hopefully, if I get sick and need healthcare, they will then pay my healthcare bills. So that's private health insurance. In many countries, particularly in many European countries, there are forms of social health insurance or national health insurance, which isn't always publicly run. It might be provided by private companies, but the key thing is every citizen must have that social health insurance. So you are compelled to have social health insurance in one way or another. So you pay in your premiums in a similar kind of way that you would to a private insurer, but it's going into a social health insurance pool that covers the whole country, the whole population. So nobody can opt out. Everybody's got to pay in. That's much more effective and much more efficient than private health insurance, because there are all kinds of risk pooling problems with private health insurance. That's social health insurance. And then finally, in many countries, there is just direct tax-funded public healthcare. And, so an obvious example of that is the United Kingdom, where the National Health Service is tax-funded. But what I would say is in most countries, you'll see some mixture of all of these things. So you will see in most countries, you'll have certainly still pay out-of-pocket costs for some elements of your healthcare. Even in a social health insurance system, probably there will be some directly publicly funded healthcare programs. You may not have private health insurance in a country with social health insurance, but sometimes you do. So again, complicated different combinations of all of these things going on. And in different countries, you might use public taxpayer money to purchase healthcare from private hospitals, for example. So very many permutations and sort of a matrix problem in all of this. So just a couple of slides on what this looks like here. So this one, I hope you can see the colors all right. This shows us what is the share of different kinds of hospital ownership in different OECD countries. So the pink bars is public hospitals, publicly owned hospitals. The dark blue is not-for-profit private, and the green is for-profit private. So you can see immediately there are, looking at this, there's only one country that doesn't have at least two, if not three, of the different possibilities there. So Iceland at the right-hand end, according to these data, I don't know if anybody's watching from Iceland, you can tell me if the OECD is wrong, but according to the OECD data, they only have public hospitals in Iceland. Everywhere else has got some combination of public and either public and private for profit, or public and private not for profit, or all three. So that's a really key thing. So it's so when we talk about public versus private, it's actually quite important to understand that in most healthcare systems, you've actually already got a mix of public and private. So we're often actually talking about, do we go more one way than the other, not do we completely get rid of private, or do we completely privatize everything? So that's important to understand. And this just shows you hospital beds, which is a very similar idea by ownership. Obviously, in a hospital, we do other things, but a lot of what we do is we put people in beds. So we like to count beds because they're easy to compare across countries. And this shows you the same thing, but really what it is showing, though, is more importantly, is if you just compare back, there's more pink in the hospital beds than there was in the hospitals. Now, all that means is that really public hospitals are bigger than private hospitals in most countries. So even though most of these countries do have a private hospital sector, in most of them, more of the beds, in fact, are in public hospitals. So that's important because that actually means more of the work, more of the activity is going on in the public sector than it is in the private sector typically. And then finally, this just shows you the share of expenditure by different financing types. Now, the OECD, they've got a slightly different categorization from what I was talking to you about. They've got what they call government stroke compulsory. So that's tax plus social health insurance. So any kind of mandated health insurance is in the pink, government compulsory. Blue is voluntary, which means private health insurance. And then the green is out-of-pocket household costs. So again, what you can see there is that every country's got some mix of those. A funny artifact of the way OECD measure this is they actually count in the US, they count a lot of US private health insurance as compulsory, which it isn't really, but in the US, most people get their health insurance through their employers and employment. So the way the OECD count it, they actually put that in the compulsory bucket. That's why I don't particularly like the way they break it down. But more importantly, though, look at that out-of-pocket. So everywhere, out-of-pocket is at least 10% of health spending. And in most countries, it's actually quite a lot more. And as we go over towards the right-hand side, particularly in poorer countries, once you get into the middle income countries, out-of-pocket spending starts to become an even bigger share. And the poorer you are, the more of a problem that is, because it means two things. If you're relying on out-of-pocket expenditure, firstly, if you are poor, you may simply not be able to afford to pay for the care that you need. Or if you do, it may bankrupt you. So a key problem in low and lower middle income countries has been what they call catastrophic healthcare costs, where you just wipe out a family's life savings trying to buy essential care for a family member. So again, though, you see everybody's got all of some mix of all of these characteristics. All right, so let's then talk a bit more about profits, markets, public versus private in health and healthcare. And I'll talk a bit about what I'd call a traditional view. So this is the kind of stuff I was taught when I was learning about this a while ago. So firstly, we have public health, which is really the discipline. Public health is a discipline concerned with improving the health of the whole population by preventing disease and promoting good health. And health in that term, the health of the population is pretty unambiguously regarded as a public good. There are all kinds of negative and positive externalities which impact on health. So negative externalities is, for example, pollution. Go well before we were talking about climate change, go right back into the 19th century, we understood that polluted water caused disease. So John Snow in London in the 1850s identified that polluted water was causing cholera, and he closed the tap in Broad Street, which stopped the cholera epidemic at that time. But there's also positive externalities. So the classic one is immunization. So if I am immunized, that not only protects me, it also protects you. So there's a positive externality from immunization. There's a positive externality from eradicating diseases like malaria, polio, all of these kinds of things. There are big positive externalities. So public health is a public good, and for many decades, there was no real argument that, well, public health is a public good, so that is the business of the public sector that needs public funding, and the public authorities need to get on with that. Healthcare services, though, have always been a bit different, and there's a few different arguments about why you might think differently about healthcare. So firstly, if I get sick, as long as it's not an infectious disease, if I have a heart attack or if I break my arm or something, you know, most of the things that actually happen to people outside of global pandemics, if I get healthcare and that makes me better, actually most of those benefits go to me. So that's a private benefit. And you could argue, okay, me and my family benefit, but you know, it is essentially mainly a private benefit. So many people have said that's fine. That makes it more of a good like other normal goods. So it's fine for this to be privately financed, provided, etc. Although there are lots of positive externalities from having access to good healthcare, not least you keep your workforce healthy, they can be more productive, you know, the nation becomes more productive, etc., etc. Where it got tricky is right at the beginning of health economics. So the very first health economists in the 1950s and 60s started, the reason they got interested in healthcare, which nobody really had looked at much previously from an economics perspective, was because medical care, or as we'd now call it, healthcare, had clearly different characteristics from kind of normal markets for ordinary goods. So it definitely failed to meet various criteria for the perfectly competitive market model that we all get taught in kind of neoclassical microeconomics. So there were asymmetries of information between the doctor and the patient. The doctor acts as the patient's agent. You can't have free entry into the market because you have to spend years training to be a doctor. So there's a very limited supply of people, etc. So all kinds of ways that it differed, as well as the fact that health and illness risk clearly needed insurance, and insurance has all kinds of issues with it. So there were strong economic arguments made as to why healthcare was different, which didn't necessarily lead people to say it must be publicly provided rather than privately, but did lead everybody to agree, look, healthcare is a thing which is always going to be more regulated and have more state intervention than most other markets. And what you do find, though, is you actually have quite different cultural norms and values about what is acceptable in healthcare and not in different countries, different ethical values, etc. Interestingly, though, and I checked this earlier today to make sure I'm not making this up, most versions of the Hippocratic Oath don't actually talk at all about profit or public or private or anything. They have some ethical values that doctors do have to treat everybody, but nowhere in the kind of history of medicine really does it say that you can't be a private for-profit doctor. So that's quite interesting, and that's actually quite a strong cultural value in medicine in a lot of countries. And in the West, outside of the communist world, I think it's fair to say that profits at some level were kind of acceptable in healthcare, but I think there were pretty strong cultural norms in most countries, even including the US, that said actually healthcare is not the same as some other businesses. So it's not an area where we expect you to make enormous profits, but you can make some profit. But then we had a big change. We had the neoliberal revolution and the new public management revolution. And I'm old enough that I started studying economics really as the neoliberal revolution was getting going. And I started working in healthcare as this new public management theory started to be applied. And that was a pretty big change coming out of the whole neoliberal movement, which, you know, you don't need to tell me what that is. But in healthcare, it had a number of quite important impacts. So in public health systems, what we saw in many countries was moves to develop what they called quasi-markets, to have kind of stimulated competition between public organizations in healthcare, trying to make them compete. You had increasingly what's described as outsourcing or contracting out, where a public agency would actually contract with a private organization, a private firm, to provide a service. Often it started with things like cleaning and laundry, but over the years has progressed very much into clinical services. So whole clinical services in many countries are now outsourced from public systems to private providers. Public-private partnerships, different complicated ways of moving money around and trying to get, the idea was always to use kind of private sector efficiency and dynamism. What it usually ends up as being the public sector taking on the risk, allowing private firms to make extra profits. That sounds cynical, but that's honestly how they've typically worked out. Trying to bring in private financing in different ways, changing regulatory regimes, and in some cases, full-on privatization. So, I had the incredible privilege of working in the former Soviet Union in the early 90s, just when everything was really falling to pieces, not in Russia, but in Central Asia, in Kazakhstan, in Kyrgyzstan, Turkmenistan. And the advice, well, what had happened in those countries was all the factories and industries were privatized, but what the people from the World Bank who told them to privatize these industries didn't realize was that actually all the healthcare system, and indeed a lot of the education system, was actually owned by and run by these state enterprises. So the hospital was the tractor factory hospital. It wasn't the public hospital. And when the tractor factory got privatized, they had a hospital that they couldn't pay for anymore. So there was a lot of privatization in fact, in the post-Soviet, post-communist era, which caused all kinds of problems. Then on the private sector side, we've actually seen a lot of change in the last few years as well. So we've seen, particularly in the States, but also in other countries with large private sectors, lots of mergers and consolidation, particularly of hospitals, but also in pathology, in primary care. So mergers and consolidation, reduced competition, increased monopoly power. Lots of what they call vertical integration. So that is where maybe a hospital wants to actually take control of the primary care practices who would refer patients to them, and they buy those primary care practices so that they become a kind of a whole healthcare system, all owned by the same entity. I spoke about many doctors in traditional models were partners working together in a self-employed way. That's changed a lot recently. Many doctors, primary care doctors, general practitioners, and specialists now actually have been corporatized. They now work for big medical chains, big medical companies as employees, and that has had a number of impacts. At the same time, particularly in America, many not-for-profit organizations now actually are forced to behave as if they were for-profit organizations. The whole kind of markets and regulatory regimes they're working in force them to behave as if they were for-profit. And that's very powerful forces there. And at its extreme in the States, but also in a number of other countries, we're now seeing private equity firms. So the BlackRocks, all of these kind of these huge, what's the other one? State Street, all of these companies, they now own large parts of the US healthcare system. So these private equity firms that own everything increasingly own actually a large part of the private healthcare sector as well. And now you're seeing various, your Googles and Amazons and these tech firms, not very successfully, but they keep trying to get back into healthcare. So they want to move into healthcare to use all of their big data to make healthcare profits. So that's going on. And finally, in all of this time, we've had increasingly globalized supply chains, which, you will have, just from reading the news, you will have seen obviously came to a head in COVID, where now most of the active ingredients for most of the drugs made in the world, the active ingredients actually are only manufactured in China or sometimes in India. So even if your drug factory's in America, you're still getting your raw materials now from China or India. So incredibly long, narrow supply chains come into place. And that's had a lot of consequences, which I'm obviously going to focus on the negative consequences. So we've seen a big loss of state capacity. Neoliberalism, you can argue about whether it was deliberate or not, but it has certainly had the result of reducing the capability of states to manage their services and their public services. We've seen supply chains become more vulnerable. They were already showing signs of this vulnerability long before COVID, but COVID has really popped it into sharp relief. You've got this cross ownership via private equity, where actually big parts of the health system are owned by the same people, posing all kinds of incentive and monopoly problems. Then under the surface, from working in this system, healthcare professionals in many countries are less and less happy, less and less satisfied, and more of them are experiencing burnout, real psychological damage, leaving the profession. Lots of ideas about what's going on. Many people blame it more on technology and things, but underneath it, I think when you talk to people, healthcare professionals hate working in these highly corporatized systems, whether public or private, but these terribly bureaucratic corporatized systems don't mesh well with the practice of medicine. And as I said, we've always had for-profit healthcare, but as these things become more corporate, as they get taken over by private equity, it's moved now so that these hospitals are just another profit center in this enormous portfolio, which is really all about rent extraction. So that's a real problem. And we've had lots of de facto privatization of commons, particularly in data and information. So lots of health data really has by accident become privatized. It should be a public good, but it isn't really. It's become privatized and captured now. So that's all really bad. And then we're back in disruption with some different pictures. The top one, hard to see. So I grew up in London and I lived for a while in East London. If you had told me that an outer suburb of London would be destroyed by a bushfire when I lived in London, kind of 12 years ago, I would have laughed at you. That's what happened 2 weeks ago. That's an aerial photo of, a large number of houses that were destroyed by a bushfire in the edge of London. So we've got all of this ecological crisis going on. We've got COVID, we've now got monkeypox, we've got resurgent polio in several countries, we've got a shocking health crisis unfolding, and we remain on the edge of the Third World War. So we've got a hot war in Ukraine, which, you know, could, and all kinds of tensions around the rest of the world. So where do we go? What have we learned? I'm going to speed up a little bit. I might miss out a couple of slides just so we have time for discussion. But look, COVID has taught us a few nasty lessons. And in this space, I think the COVID vaccines have really just given us an extraordinary insight into some of the inequities that are caused by the current way we do things. So you all know the story. The high-income world, or the richer end of the world, got all the access to COVID vaccines in the beginning, and our ability to get vaccines to low-income countries and lower middle-income countries was terribly compromised, and the profits were all available really from the rich world, so that's where the vaccines went. But yet, all of these vaccines were built actually on publicly funded innovation. So the mRNA vaccines, which were being used, all the original basic research was actually publicly funded, but that's then privatized by the pharmaceutical manufacturers who take those that basic research and patent it and get the intellectual property protections. We had a really bad international response of not making sure that the vaccines were equitably distributed. And we've ended up actually with incredible monopoly power from a very small number of the successful vaccine manufacturers. And now that we all have to have boosters, and it looks like we're going to have to keep on taking these vaccines for years and years, that's an extraordinary rent extraction opportunity for these monopolies. So that's incredible. And we have not somehow, in a way that is extraordinary to me, we have not followed up as governments to really take control of the search for more effective vaccines that will prevent transmission. We've just left that still to the market. So my bet is, if we do get like these nasal, intranasal vaccines that people are talking about, which may actually stop transmission, I'm afraid, I think they're going to go the way of the other vaccines. Big pharma will take them to market and will get all the profits out of them. So if we want to avoid that in future, we need to think about big changes to intellectual property laws. We need to look at actually making publicly owned intellectual property. We may even actually have to have publicly owned manufacturers to just make this stuff for the public good in the public sector. And or maybe we need to come up with different rewards for innovation. So we no longer give pharmaceutical companies a patent, perhaps, but we maybe reward them in other ways, the discoverers and the people who actually bring these things to the market. Maybe there are ways we can give them a lot of money, but not actually leave them owning that intellectual property in perpetuity. We also saw really the impacts of the loss of state capacity that neoliberalism has brought around. So my home country of the UK has wasted and spent billions and billions of pounds on basically failed contracts, many of which increasingly look like they were corrupt. And that is a direct consequence of the kind of downgrading of the state's capability to do the work. So things had to be contracted out to the private sector because the capability to do the work didn't exist within the government. And then also the capability of managing this procurement rigorously without sliding into corruption and wastage. And then finally, COVID has actually caused very direct damage to the most important asset in our healthcare systems, which is our healthcare workers. So that problem of burnout that I was talking about has been massively accelerated by COVID. Healthcare professionals are distressed and under enormous pressure by COVID, continuing on, even though we now tend to lead our lives much less impacted by it. In the healthcare system, it's a different story. Our health workforce is under unbelievable pressure and they're suffering terrible damage from it, whilst there's the real chance that there are long-term effects of COVID, long-term health impacts, which are going to be with us, be with many people for many years to come. So that's just COVID. We had many challenges, like I said before we arrived at COVID. And in 2019, WHO came up with this list of what they felt were the top 10 threats to global health in 2019. Well, they were nearly right with the global influenza pandemic. It wasn't flu, granted, it was a coronavirus, but they were pretty close. Air pollution and climate change, non-communicable diseases, diabetes, heart disease, all these things. Fragile and vulnerable settings, the fact that many people in the world live in such poverty and in such fragile states that they can't access basic care. Antimicrobial resistance, a real threat to healthcare everywhere, that we're losing antibiotics. Vaccine hesitancy, which has been shockingly accelerated by COVID, all the misinformation and disinformation about vaccines. We've now got vaccine preventable diseases popping up all over the world because vaccination programs have been impacted. And then this is my list, which is far too long. I'm not going to read them all out, but we actually had lots of healthcare that we were providing to people that we probably didn't need to provide to them, that was wasteful and not very beneficial. We're not very good at caring for people with chronic conditions. We're often not really doing the right things that people need. And we still, even before COVID, had this problem of burnout. And the real problem, which is that healthcare has become increasingly technological, kind of production line focused, yet at the heart of real care is personal caring relationships. And that's what I think is actually going wrong with health worker burnout, is that our people are not being allowed to care properly for their patients. So lots going on there. And this graph just comes back to this problem of inequity. So in this graph shows you healthcare expenditure along the horizontal axis and two measures of health outcomes. One on the left is called health adjusted life expectancy. On the right, a different measure called mortality amenable to healthcare. And what we see is that in the poorest countries, for every dollar we spend on extra healthcare, we get really big, large increases in health outcomes. But then we get up to a level which is basically at the level of where lower middle income countries are, is we start to see the speed of improvement in health outcomes starts to level off, slow down. We're still getting good improvements in outcome, nearly a 45-degree line, but it's slower. And then at some points in the high income world, usually in these analyses around maybe where Southern European countries are in terms of their healthcare spending, we certainly are seeing no more gains to health expenditure, and we might possibly even be seeing reductions in health status, although that's a more complex argument. So we've got a real problem of inequity, and so many people in the world do not have sufficient access to healthcare, while many people in the rich world, arguably, as with so many other things, might actually be consuming more healthcare than they strictly need. So how can we do that? How can we get health and healthcare into Kate Rayworth's donut? And I know you had a session about the donut there. It's the same concept really here precisely. So wrapping up then, here are just kind of a couple of my thoughts on, as we move through this period of disruption, which I don't think is short term. I'm afraid to say I think it's a longer term period of disruption that we're going to be in. And particularly as we might think about what does it mean to be in a post-growth world, which I'm sure you've talked about post-growth theories and thinking in this course too. what do we do? How do we organize healthcare for that world, given, as I said at the beginning, modern healthcare is actually a child of economic growth. It wouldn't be here without that economic growth. So I think we need to come back to these things I talked about at the beginning: complexity, resilience, scale in healthcare systems. And we've got some trade-offs and dilemmas here. So degrowth, particularly degrowth thinkers, like to think about moving towards more local, smaller scale organization and production, local democratic organization, all that sort of thing. There are very strong arguments for doing that in some aspects of healthcare, not least because a smaller scale of healthcare could help actually with this challenge to bring back caring relationships. However, the supply chain of healthcare is inherently highly complex, highly technical, large scale. If we still want to have the kind of modern pharmaceuticals that we're using, we are not going to be producing them in the village cooperative pharmacy. We are going to still need to have pharmaceutical manufacturers with incredibly high-tech plants doing this with very complex raw materials. So how do we balance relocalizing with actually the very high-tech complex end of the supply chain, which is never going to be possible to do locally? When we think about private and public, it's very easy to jump one way or the other, depending on your ideological preferences. But the key challenge in the post-growth world is not necessarily that you can't make a profit. I think you can still make a profit in a post-growth world, but you can't make increasing profits over time. By definition, if the economy isn't growing, you are not going to be able to grow your profits unless it's at the expense of somebody else, which we can't do in a steady state or degrowth economy. So for the private healthcare system, the problem is about profits. And we have to have very hard conversations with people about you will not get the rate of return that you're used to getting. And private equity funds need to be pushed out of healthcare because they drive requirements for ever increasing rates of return. So that's very hard. On the other hand, it is still far from clear how we will actually fund public welfare states in post-growth circumstances. Again, the very development of the welfare state came from growth. And finally on this, how can we do all this that we want on demedicalizing, moving back towards care, whilst actually getting the benefits of technologies, precision medicine, digital, artificial intelligence? Where's the trade-off, the wicked problems there? So I think we need to do a few things to get started on that. We need to rebuild the state. We need to insist that public goods belong to the public and that we get profit and rent extraction out of public goods. We have to address these global inequities. We have to let go of neoliberal thinking. If you're like me, my whole career has been spent in a neoliberal world. That's how people have learned how to do things. So there's a big change there. We need to talk about profits and have a different social compact. And we need to think hard about how can we have organizational models for healthcare that can connect locally, be more democratic, but actually still allow highly professional, highly specialized people to do very technical work. That's complex. I'm not sure how we do that. We need to start talking. And we're going to have to reconstruct our healthcare systems after COVID. So now's the chance to do some of this stuff. We all talked a lot about this in 2020 and it didn't happen. It doesn't mean the opportunity is still not there. So here's a few readings, which I recommend, not really a full reference list, but some good stuff in here, some of it by me, but you could read the other people. And thank you very much. And I'd love to take questions and discussion now. So thank you.
Thank you, Dr. Martin. like it was standard presentation, and I believe like all our participants had the chance to learn and enjoy this presentation. So we are now going to begin answering the question that we already submitted. And as a reminder, like you can always submit your question from the question bar in the bottom of your control panel. So we have a question here from Hensher, I think, if I pronounce it yet. So if you want to answer your question directly, the floor is yours.
Okay. Yes, go on, Madhushri.
Yes, that's correct. Hello. Thank you for your great talk. It's a very pertinent topic, and I loved how you addressed the degrowth aspect and the question of finance. So my question, I come from India, and we also have a big burdened healthcare system. And so I wonder, what do you think the role of young researchers, practitioners, and academics is in, mobilizing for better healthcare in a transnational settings? Because these things affect all of us. And what sort of political approaches do we need? Thank you.
Okay, thank you. A fantastic question. So I'll try and divide the two. So I think as researchers, practitioners, etc. I mean, look, there's a whole load of advocacy things that you need. You must be guided by what you want to do the advocacy about, but I'd maybe take your question more professionally, kind of how to do the work. So for example, if you are in India, but you want to have an impact transnationally, there is actually, look, the Indian healthcare system has all kinds of problems and et cetera, but there's also incredible innovation in India about how to provide ultra low cost but high quality care. So for example, you have I apologize, without looking it up, I can't remember the name, but you've got the chain of hospitals now which does very high quality surgery at tiny fractions of the cost of what those surgeries would cost in other countries. You've got really interesting sort of not-for-profit models of care moving in. So I think if you were interested in doing research about what is the very best of the new innovations in Indian healthcare, and then putting that very deliberately in the international literature, not publishing in Indian journals, but very strongly getting it out internationally, and working on getting in front of international institutions like WHO, World Bank and stuff, that would be a fantastic contribution, perhaps, that you specifically could do. Because my view is, having worked in low, middle and high income countries, honestly, in the post-growth period, high income countries need to be learning from middle income countries, the countries like India, where, there's lots of problems, but there's also incredibly good practice, and we need to be learning from you. So I think researching that and getting your findings about the best of Indian healthcare out there would be a fantastic way to do that. And then politically, well, look, if I really knew the answer to that, I'd be in politics probably rather than sitting here. But I think you have to think ahead. So you watch, we watch crises unfold and everybody runs around. What we need are people who've worked out plans and responses in advance. Now, no plans ever, you can never anticipate exactly what's going to happen, but we can be thinking now about what would post-growth healthcare systems look like, so that when we finally are flipped into the real post-growth period, we can turn up with those plans and go, hey, look, we know how to do this, look at this. And I think that's a big job, both as a researcher, but also as an advocate. There's really interesting, but still quite technical work to be done in that. And I think, honestly, there might be more mileage in that than trying to persuade current politicians to do these things right now. So I hope that helps, but they're fantastic questions. Thank you.
We can't hear you, Reda.
Thank you for your question. I'm sorry. Like we have one more question from Vladislav. And you want to ask it now? Perfect. Go ahead.
Hello, can anybody hear me?
Yeah.
Lovely. Thank you, Professor, a lot. That was very profound. I wish the Summer Academy started with this lecture. I'd be much more excited then. But no hard feelings. It's absolutely fine. My question is, I'm from Ukraine myself, and with all the problems that Ukraine has, it also has a tax-funded healthcare system. Now I'm in the UK, which very prides itself in the NHS, and it's absolutely worth it. So my question would be, for the sake of the UK and Ukraine, how do tax-funded healthcare systems, what do they need to do? How do they need to change in order to face the crises that we have and to be fit for purpose in the upcoming, let's say, 20, 30, 50 years? Thank you.
Yeah, no, fantastic question. And, you know, I'll tell you what I think, but, you know, lots of people think different things. And again, we could write a book about that, couldn't we, really? But I think, look, on one side, the key thing tax-funded systems need to do, or need to be trying to persuade, is to make sure that there is actually adequate taxation to pay for the system that you need. So, I mean, honestly, looking at the UK at the moment, it's a shocking mess. You now have this terrible leadership battle going on in the Tory party, which all they're talking about is cutting taxes, even though the country's already in a shocking fiscal position. So I think, as much as anything in the healthcare sector, healthcare leaders and professionals need to be making sure that your country's macro and fiscal policies are actually giving you a decent tax base. And critically, the tax cuts are not the way you get that. You know, we just keep on going back to that kind of Reagan era voodoo economics. So that's crucial. On the other side, though, what can the healthcare system need to do? I mean, look, you know, I wish you obviously the best and for victory for Ukraine in this situation. But the truth is that often, well, most typically out of war comes really big fundamental change and reconstruction and opportunities that people try to do reforms of healthcare systems in other circumstances. But honestly, if you look around the world, most big reforms actually have tended to happen after a war or after some massive crisis. So it's in a terrible way, but once out the other side of the war, this is an extraordinary opportunity to rebuild and refocus the healthcare system. And I would say for tax-funded systems, what we learned and what the neoliberal experience spent a long time trying to erase from our brains is that you have to not be scared to prioritize. And you need to be clear about where your priorities are for the healthcare system. And they clearly need to now be about prevention, about primary healthcare, about effective management of chronic diseases. And that's where the money needs to go. And that's where the people need to be and where the professional status needs to be. And yes, of course, you want to have advanced, complex specialist care, but that you can ration, that you can control. And if people out there, if everybody has really good access to very high quality primary health care, basic hospital care, that is actually what gets you the best health outcomes for the population. But you have to be willing to prioritize and use all the techniques, cost effectiveness analysis, sectoral cost effectiveness analysis, not be scared to use those techniques. Again, kind of back to this question of low income versus high income countries, I and others have used sectoral cost effectiveness analysis in lower income countries highly effectively, but people freak out at the idea of doing that in high income countries. That's ridiculous. In the kind of challenged environment we're all going to be in the future, we need to use those techniques, sectoral cost effectiveness analysis in particular, to make hard priority choices and to make sure that every dollar we spend is on the best possible value application. So I hope that that's helpful.
Thank you so much, Doctor. Like considering the time frame, like we have mostly full questions from participants. So maybe I will go with Gustav, which is a member of our Orga team. Unfortunately, he won't be able to ask his question directly, so I'm going to read it real quick. So in the global south, in general, public health institutions are characterized by better qualified doctors as compared to the private institutions, but high inavailability, no show of those doctors. So how to tackle this dichotomy, Professor?
Okay, brilliant question. I'm not a specialist in that, but I understand precisely the phenomenon you're talking about. I mean, look, the simple answer, if you had the magic wand, is actually really better paying conditions in those public services for the public staff. You know, and I think there is quite a lot of work around now which does show that you do actually have to pay people more, and if you pay them a bit more, they will show up more. They don't need to be doing their private practice on the side, etc. So that's important. But you know, of course, that involves having the money. So I understand that. I mean, we've also got all of these problems of you know, brain drain, and obviously lots of health professionals leaving lower income countries to go to high income countries, etc. That I think is something we do need to be thinking about. But I think it's also, money isn't everything, but we are human beings and we all crave status. And I think there are other things that we perhaps need to be thinking about how do we improve the status of healthcare workers in these particularly resource constrained settings, particularly in the public sector, again, and improve their job satisfaction. So yeah, look, no magic answers for that one, I'm afraid, but I hope that's sounds reasonable at least.
Thank you. Like we have one last question, if you could take it. Perfect. So like we have a participant, so Amul, so he may ask his question live. Perfect.
Yeah. Hello, Professor. Thank you for your talk. So my question is, can we not promote healthcare as a fundamental right and not a good or a commodity? If we call healthcare as a good, then it is going to be sold as a commodity, because the influence of neoliberal thinking is like much like they are more influential, and they have all the arguments against publicly funded healthcare system like capacity, efficiency, corruption, etc. So if we call healthcare as a fundamental right, then it is out of purview of the market. So I was yeah. So what are your views about?
Okay, so two things to say. So I would certainly agree that we should make access to healthcare, or basic access to healthcare, definitely a human right. And the whole movement for universal health coverage is trying to do precisely that. I think where it gets tricky, and where many people, where the argument is, you know, there are still people who say we shouldn't have universal health cover, but you can't kind of ignore them. Let's assume that we have universal health cover. And I think in the last few years, really there's more consensus now that actually the only way you have universal health coverage is through public financing. I think the argument is finally being won on that. But people will still argue, though, well, that's okay. We need a public universal health insurance scheme, and then that will contract, that can buy care from private practitioners, private hospitals, etc. So you don't need to have private provision. So there's still an argument about that, and there's still it's not just an ideological argument. I think we need to be clear about that. For some people, it is ideological. Personally, I favour public financing and public provision systems, but in Australia and in many other countries, the biggest fight you could ever pick politically would be trying to force all doctors to become public employees. So doctors don't like that, and that is often would make it politically impossible to actually force everybody into a public provision system. So many people would argue, don't bother with that fight. Just, we can have publicly financed universal healthcare, and then you can still have private involvement. I would say the way to beat that is, in fact, to strengthen your public healthcare system so that it actually becomes a better place for doctors to work than their own private practice. And you need to do a lot of things to do that. You need to spend money to make your public facilities and services good and good places to be. But you also perhaps actually need to skillfully regulate down the ability to charge for private care, charge private health insurance, etc., reducing out-of-patient pockets without ever quite banning it. But you need to make it more and more difficult over time. And eventually you'll start perhaps pushing more of the doctors into the public sector. And then, you can achieve that. But yeah, look, it's a tough one. And as I say, that's not just ideological. Lots of health reform initiatives in many countries have failed because they were really trying to nationalize doctors, and the doctors weren't having it. And you can't have a health system without doctors. So if the doctors don't want to do your reform, it's not going to happen. So there, you have to be very pragmatic about the politics of that.
Wonderful. So thank you again, Dr. Hensher, for answering this question and for the great presentation. It was such a pleasure to have you with us. So this concludes our today's webinar. Thank you all for attending, and we hope that you learned and enjoyed this presentation.